This is Dr. Stephen Zuckerman in Baton Rouge, Louisiana, and I'd like to talk a little bit today about functional neurology, meaning that there really isn't any physical or physiological basis for the patient's symptoms or signs, but rather it's more of a psychological nature. Now, when I trained in the 1800s with Sigmund Freud, we learned that there were two types of conversion reactions, i.e. non-organic basis for physical complaints. One of those is a hysterical conversion reaction in which the person doesn't realize that there's really nothing which is causing that symptom physically. Whereas the second type is an actual malingering in which the patient is aware of the lack of physical disturbance, but rather is having those symptoms for secondary gain, whether that be financial or psychological, it doesn't matter. Now, when we evaluate patients and perform the tests that I'm going to discuss in a little while, to some extent we can distinguish those people with physical problems from those people who do have a conversion reaction, but in no way is this talk intended to imply that we can furthermore make a distinction between those that are malingering from those that are hysterical. So that needs to be kept in mind, as well as the fact of despite all of these techniques, none of them have been proven to have sufficient validity to be able to 100% diagnose somebody as being malingering or having a conversion reaction. So best to keep an attitude of abject humility, because as I've gone on in my career, in which everybody points out is an extremely long one, I learned more and more how many mistakes I can make. And so, despite having this knowledge, just don't think you know it all. So one of the first things we'll talk about is what are those motor signs which are indicative that the patient really doesn't have a physical basis for their weakness. Well, the exam actually begins either before they come in the room, and you can observe them in the waiting room and see what their motor activities are, or when they're leaving the exam room. So it doesn't actually end during the formal in-office consultation. So it's good to see if there's a discrepancy in what their functional abilities are when they're not aware that you're observing them. Now, when you do a formal muscle exam, there is a terminology of giveaway weakness, and what that refers to is that the patient will have a certain ability to resist any attempts to get that muscle to fall away or not contract well, and then all of a sudden that muscle will become extremely weak and it will fall down. Now, that's sort of a thing you get with experience. It's not easy to recognize that immediately, and again, doesn't really have a significant ability to distinguish those people with functional from organic weaknesses, though it is something that is an indicator that would raise your index of suspicion. Another pattern which would also be non-physiological is so-called co-contraction, or the simultaneous contraction of agonist and antagonistic muscles. So, for example, if somebody is told to flex their biceps and you feel their triceps and can feel that there's actually some triceps contraction, that's clearly somebody who is not trying their best. Now, one of the most established motor signs which would indicate a conversion is the so-called Hoover sign. And that is performed by keeping one palm under the heel of the affected leg Well, you ask the patient to extend or flex the hip, and so ostensibly you're checking the strength of the leg that's being lifted up. But in actuality, what you're doing is seeing whether they are pushing down with the so-called affected leg's heel, which you really have to do physiologically in order to get the traction you need to push up with your good leg. So what you're going to do is to compare how well they push down with the affected leg's heel when they don't know that they're supposed to be pushing down with it, and then you ask them to push down with that leg, and you see if there's a discrepancy in the involuntary from the voluntary. Another way to approach this test as well is to see whether in the unaffected leg you have your palm under that heel. When they push up with the so-called weak leg, are they pushing down with the other leg? And is there a discrepancy in that leg when it's being used voluntarily and involuntarily? Again, it's not a 100% test. It's probably the most valid test that there is for detecting inconsistent motor reaction. Now, there's, again, done in both hip extension and hip flexion. Now, another test is the so-called test of the sternocleidomastoid, which, as you know, if there's weakness of the left sternocleidomastoid, the chin won't be able to push to the right. And so if somebody has an apparent left hemiparesis, you can test the left sternocleidomastoid and see whether or not there is actual weakness in turning the head to the right. Now, they don't know, most people don't know that the sternocleidomastoid pushes the head in the opposite direction, and so you can actually ask them to push their chin against your hand towards their weaker side, which is an implication that it should be weaker going towards that side. And of course, it should actually be weaker going towards the other side, or not weak at all if there is in fact an upper motor neuron problem, given that the sternocleidomastoid has bilateral innervation. Now, in the particular case of lower back pain, here are some of the tests that are used for malingering. Again, you've got Hoover's sign, you've got Waddell's sign, which is pushing down axially to see if it reproduces some of the symptoms. Most of these have not been shown to be very helpful in distinguishing. One test that I use is this distraction test, and what I'll do is see if there's a huge discrepancy in straight leg raising positivity. When the patient is lying down flat on the bed, you raise their leg and see at what degree they have severe pain, and then I'll have them sit up and ostensibly either check a Babinski reflex or do a joint position sense. But in the meantime, what I'm doing is actually flexing their hip to 90 degrees, and if they can tolerate that without any indication of discomfort whatsoever, I think that suggests that there is not really any significant stretch on the sciatic nerve, and I would conclude that there was something that needed to be explained there. So those are the motor signs. Now we'll talk a little bit about what we're looking for in sensory disturbances, which would again raise a flag that there may be some non-organic pathology at play. Of course, one would be a non-anatomical distribution of a sensory loss. So if someone complains of numbness in their leg, and there's a strict demarcation of reduction of sensation either at the shoulder itself or at the hip, of course that doesn't conform to any known pattern of dermatome or peripheral nerve distribution. Or let's say it's strictly up to the knee in a circumferential distribution. That's got to be suspicious. A not infrequent complaint for a patient is to lose sensation on half their body. Now, some of those people are going to have thalamic infarcts or pathology, but some of them are not. So what are the ways to examine those patients to see whether or not you think that it's physical or non-physical? One approach is to say that the body is not made such that strictly in the midline there's a distinctive difference in perception of, let's say, pinprick, because there's about 2 to 3 centimeters of overlap. Now, as it turns out, that's not a very reproducible way to distinguish those that are malingering or those that are having a conversion reaction. More common test is to use the tuning fork, and that's done by taking the tuning fork and putting it on one side of the midline of the frontal bone, and then compare it to the other side. Of course, the vibrations get transmitted via the skull and should be equal. And if they say that there's no sensation of vibration on the so-called affected side, that's very suspicious. And going along with that, a lot of times people will have unilateral hearing loss on the affected side, which shouldn't be physiological, or even visual loss for areas that should not be affected. So those associated features can also be helpful. And then finally, in the physical exam, there is a particular gait that is described as astasia abasia. And basically what that looks like is somebody who is on a tightrope walk and is wobbling to and fro, and it looks like they're going to lose their balance, and then they catch it, and then they may go to the other side. And as it turns out, it's more difficult to do that, and it requires a greater sense of joint position and balance, etc., than it would if there was actually a lesion. And so you have to be able to recognize that kind of a gait. And then there's some other tricks, such as having the patient walk down a hallway closer to one wall, and they'll fall towards the right side if that wall is closer. You have them turn around, and then they'll fall to the left side as that wall is still the closest wall, which is clearly inconsistent. So those are the physical diagnostic signs. Now let's say someone has an apparent loss of vision. Well, some patterns are readily recognizable, such as the so-called tunnel vision, in which case the patient has an equal loss of vision up close as they do far away, and so it's like they're looking in a tunnel. And of course, that's not physiological. You would expect the visual fields to enlarge like a cone, and that's how the visual loss would be present if there was one. Another pattern that to me is suspicious is monocular diplopia, meaning that if they cover one eye, they still see two objects. Now, of course, there are some rare ocular pathologies which can cause monocular diplopia, though in the neurological setting, it would be extremely impossible to have that on a brain basis. Now, there is a great YouTube video, which I have on here, by Dr. Timothy Root, 20 exam tricks for tricky eye patients, and I highly recommended that you look that YouTube video up, or it will be available as this gets posted. And then, since we're on the subject of non-physiological events that neurologists tend to evaluate, we have seizures. And if someone has generalized tonic-clonic seizures, there have been certain characteristics of those seizures that have been proven to be indicative that they are not physiological events. One of those would be side-to-side movements of the head. There's nowhere in the brain that activation can cause that pattern pattern of movements. Interestingly enough, only patients with psychogenic events close their eyes during the ictus. Epileptic events keep their eyes open during the whole time, and here is the reference for that. Certainly movements that are out of phase. So if one leg's going up and the other leg's going down, not an epileptic event, not a seizure. And there isn't any representation in the brain during activation which can cause either pelvic thrusts or arching. And so if those behaviors and motor activities are noticed or recorded, again, very diagnostic that it's a non-physiological event. And as it turns out, the observation that people who have very loud, stertorous breathing after their ictal event are also not having a physiological event. So that's a brief overview of some of the techniques that we can use. It's actually been estimated that fully 1/3 of patients that are referred to a neurology outpatient clinic do not have a physical basis for their complaints. And so we're in the field of recognizing those, which after some experience neurologists are pretty good at. But again, you have to keep in mind that we do not have 100% accuracy. And furthermore, patients who do have functional complaints can also have organic ones. So just because you've detected what you believe to be is a non-physiological reaction doesn't mean there's not also organic pathology. So that's all I've got to say on the subject, and thanks for listening. Bye-bye.